So today I'll take you through a extremely challenging case that we had to do today. This patient had aneurysms on both sides. On the right side, the injection would show a very small ecom aneurysm, and on the left side, we had a large communicating artery aneurysm coming from a very tortuous dysplastic segment. So, what were the challenges that we had with this case? So before I go further, let me give you a short or a brief history. This is a 63-year-old female. She presents with sudden onset of headache. She came to us within 24 hours of this episode. She has no comorbidities. On arrival, she's alert, she's oriented. The only problem she has is severe headache. She has no neurological deficits. The CT scan shows diffuse subarachnoid hemorrhage. It involves the sylvian fissures, the basal cisterns, and also there is this flame-shaped bleed in the region of the anterior commissure, which is very strongly suggestive that an anterior communicating artery has ruptured. We take an angiogram from the right side. You can see the vessel is tortuous, but not too bad. But what is important is to see this aneurysm. This is really, really small. It's 1.6 millimeters into 1.9 millimeters, arising straight off the anterior communicating artery. You can also see that the neck is reasonably wide. So we have the opportunity of putting one single coil. The second coil can prolapse out. It's technically difficult to put a balloon across this and then cannulate this aneurysm considering the size. Now we must remember at this point of time that small aneurysms of these are challenging because they're very prone to rupture, especially if they have ruptured in the recent past. When we took an angiogram of the left side, we find another aneurysm. The vessel is very tortuous. There is a very tight hairpin bend at the point where the petrous segment is joining the cavernous segment. You can actually see this is the ophthalmic artery taking off from here, a very tight loop, and then there is a narrowing just as the vessel enters the dysplastic segment, which in turn gives rise to this large aneurysm here. There is a daughter aneurysm at the base or close to the neck. The vessel beyond it again shows little bumps and again is dysplastic. So what is our plan of management? Normally, when we decide to put a flow diverter or a stent in the patient who has ruptured, we would load them with a combination of ticagrelol and aspirin 2 hours prior to the procedure. Now, the problem in this patient was that we have an aneurysm which is very small, and so we did not want to have this patient on antiplatelets at this point of time because if there was a bleeding, it would be a disaster. So we decided to coil this aneurysm unassisted without any drugs. Immediately following the coiling, we loaded the patient with 180 milligrams of ticagrelol, that is Brilinta, and 325 milligrams of aspirin. And then after 3 hours, we went ahead and coiled the aneurysm and placed the flow diverter. So we started the procedure approximately about 2 hours later so that we had a patient who would be fully primed with the medication by the time the flow diverter was placed. So the plan was to place a flow diverter and also simultaneously coil the aneurysm. Now this is how the aneurysm on the right side was treated. Normally, I would have used a Cat5 in this case as through a long sheath like the Infinity. But since we were planning to treat the opposite side using two microcatheters, we decided to take a Navion through infinity. Then we pre-shaped the microcatheter. We gave a right angle curve, then at a distance of 16.5, which was the exact measurement from the origin of the uh, ACA to the point where it enters the aneurysm. So that is the 16.5 millimeters of length. And then we gave a little 2 millimeter right angle curve to this. Why did I use the duos? It's the most trackable microcatheter currently available. It is basically a nitinol braided microcatheter, and the profile is small. It's very, very trackable. May not give great support, but the point is here we were more looking at a micro that would never jump suddenly forward and cause a problem. So you can see what is done. You can see the navion that has come all the way up here close to the cavernous segment. And you can see the microcatheter that we have taken beyond the aneurysm. And then we just gently pull it back and it drops in. That's the advantage of the two curves that we had created so that it will fall into the aneurysm and we place just one single coil. Now, what was the coil that we used? We used a nano coil which was 1.5 millimeters in diameter and had a length of 2 centimeter. So you can see it's obliterated the lumen and we got a safe, secure position. And then we planned to go and start the second procedure, which was basically, like I said, lowering the patient now with a very stiff dose of dual antiplatelets. Sometimes when the patient is supine, it's very important to understand that anything you give through the Ryle's tube can stay in the fundus of the stomach. And so it's important that we give these medication and elevate the left side, keeping the right side dependent so that the drugs go down into the duodenum. This is what we did. And after this was done, we waited for some time, like I said, for approximately 2 hours, and we started the next procedure. Now, this is one of the working angles. We needed several working angles to do this. We wanted to keep the flow diverter just proximal to the origin of the anterior cerebral artery. Remember, this is a patient who's got a bleed. There's a chance of spasm. It's not a great idea to cover vessels at this point of time. You can see a very tight loop at this point of just as the aneurysm originates. The daughter aneurysm just below that, or a dysplastic segment, a narrow segment, and a very, very tight loop as it comes down. Obviously, it is going to be difficult to get the flow diverter to open across all these segments. And whenever we have such long dysplastic segments, it's important that we use a longish flow diverter so that you can pull push much more effectively. If you have a shorter one, which is very precise, you'll find it gets very challenging because we come to the point of no return very, very early. Also, in this case, we had to remember that this is an acutely ruptured aneurysm, so we will have to place two microcatheters. So the 6-string Navion is good. It is able to take both the ST27 and the SL10 side by side, which makes it pretty easy to do the procedure. But the problem we realized was it was very, very challenging or impossible to cross this segment. So what would happen is whatever curve we gave over here, it would either go into the aneurysm, or if it even went beyond it, it would just flip back into the aneurysmal sac. Now we started off with the regular Traxxas wire. Regular Traxxas wire has a big challenge because it's difficult to put a tight curve onto that. And even if you put a tight curve, it does not stay. We tried this for quite some time. We even used the combination of a right angle catheter and the wire, but the problem was the same. It would go a few centimeters into the vessel, then drop back into the aneurysm. The same problem was faced with the Traxxas and the Traxxas EX wire. So normally what we would do is this. We would actually allow the wire to coil in this direction and exit out here, right? So it's like saying that you would allow this loop to form and it just goes up this way. Now, in this case, we cannot do that because a ruptured aneurysm, the tension crossed by the wire inside the aneurysm can cause it to burst. Finally, not sure of what we should do again, we actually we actually went ahead and used the Traxxas, not the Traxxas, sorry, the synchro support. Now, the synchro support, as you know, was given to us for evaluation primarily for the use of a large bore device like the Navion itself or even a large suction catheter. But look at the behavior over here. We have the Navion down here, the microcatheter is here, the extra support synchro is here, and it starts moving forward. Now, the synchro's extra support has an advantage. It's a better shapeable tip than the classical synchro. We could definitely give a better shape, but this was not the reason. It does not buckle in that easily because the tip, though soft, is not as soft as the soft catheters. In addition, it's an extremely torqueable microcatheter, so giving a 1:1 torque. The combination of a stiff, very torqueable microcatheter with a reasonably soft distal end makes it a good mic wire to take across the segment. But remember, it builds in tension. I talked about it before, how it induced a rupture in a patient when we went through a very tortuous segment in the ACA. So the important thing is to keep a close watch and do it slowly. You can see the wire moving, and here we have the wire is reasonably distal. Now what we do is we take the ST27. See, the ST27 comes here, but remember the problem here is this aneurysm has got a shelf as it joins the internal carotid artery. So when it comes here, it doesn't go, it gets caught here. Can you see that? It's getting caught. So now this wire makes another big difference that other wires don't. So we push the wire more distally. Like I said, be careful as you push this wire. We push this wire distal, and now we have the stiff end across it. The vessel is absolutely straight. And as we push, you can see what happens to the XC27. It actually takes the bend and leaps forward. Dangerous, I know at times, but at the same time, this I technically is impossible with the soft wire because this maneuver would just not be possible. So now we got the XT across. Remember, as you take this across, that you take away all tension from the wire so that it doesn't suddenly move forward, which is very, very possible because of the very high tension in the stiff part of this wire proximally. So now we have the microcatheter across, uh, and we are ready to deploy a flow diverter. But remember, this is also going to be a big challenge. We cannot see the anatomy in one view. We had to use a biplane in multiple views. And we also did not want to cover the ACA out here, primarily because I said there is the spasm can induce a stroke where collaterals will drop, and we were not very keen to do that. We use a 4 millimeter into a 30 millimeter flow diverter. It was a little longer than what I would ideally use, but like I said, we were wanted to be make sure that do a convenient pull and push. We got an SL10 by the side. You can see the micro on this end, the SL10 this side. And very important to understand before you start putting the flow diverter, place a few coils. Why is it important to do that? Because the microcatheter inside the aneurysm will tend to move a lot as we start pulling back on the microcatheter, which takes the flow diverter. So as you pull down, there is a tendency for the micro to go forward. It can perforate the aneurysm. But if you got some loops over there, this will not happen. The coils will not allow the micro to really go forward and pierce the wall of the aneurysm. So here we used a few coils, and you can see this what's going on here. We can show you what really happens. We actually deployed it in the MCA, pulled it back, dropped down into the ICA, maybe a 1 or 2 millimeters more proximal than we would have ideally wanted, but that was okay. So we are showing you how we deploy. You can see this. We come back. Now, the most difficult component was going to be this loop because this tight loop was going to be challenging, and that's why we had the extra length to do the maneuver. So we can see this here. We are doing the pull and the push, the pull and the push. You can see we are pulling, pushing, pulling, pushing several times. Actually, it took a long time to really get this, but it's important to understand that this is the best time to get this open. So you can see this. This is finally open. We do not know what is the length you actually need to open to get this open here. And that's why you need that extra length to do this maneuver. Otherwise, you'll be stuck with a hardly any segment here, and you will end up in not able to open the segment. And sometimes they can be so tight, even a balloon will not go. So look at the end result. It looks pretty okay. This segment is definitely opened up well. But if you look at the picture above, you see this segment is not open. So why does this not open? When we push on the flow diverter, it will tend to buckle into the neck of the aneurysm, rather oppose onto the wall, because this point has got less resistance than the straight segment. Also, the pulling technique is not a very safe technique here because this is very close to the distal end of the flow diverter, and as such we already were compromised. We already were about a millimeter or two below where we exactly wanted. Now, if this patient did not have an acute bleed, we could have started a little more distally in the MCA, covered the AC and come off, and then this could have been a little more easier to do it. So then in this situation, if you want to make sure this opposes, the best thing is to first try the massage. We try the massage, you can see the microcatheter over there, but it was not optimal. You cannot take a Navion across that. It's extremely dangerous. It may actually pull the whole system off or do more damage to it. So we took a balloon. This is a 4 millimeter balloon. We actually used the Scepter C because it runs over the wire. And in case we had any problems, we did not want to have the wire slipping out. And at the end of it, we get better position. It's still not flawless, but it's close to what we ideally wanted. And we are happy with this. And look at the check angiogram. This shows stasis. It shows filling of the vessel normally. It shows we are good opposition, and we were happy at the end result. So in conclusion, this is a very challenging case by every standards. One, of course, you have a ruptured aneurysm. We are not sure which is the one ruptured, an extremely small aneurysm, or is it the large one? One needs a flow diverter. That would mean the patient needs antiplatelet. The other one is so small that you have to be careful that you do not rupture it. So we decided to do one without any antiplatelets, then load the antiplatelets, go over to the opposite side and do that second half after 2 hours. We also showed you how none of the wires could actually go through across the neck. It was only the synchro support that went through. Like I said, no other wire would have gone through this because we tried everything else. And not only that, even if we crossed it by some way, the XC27 would have never crossed that shell. We needed that support to pull the wire off and straighten the vessel sufficiently. So one has to remember it's a dangerous wire if you do not have experience using it. To be extremely careful as you handle it, always putting counter backward traction as you take the micro forward. We also showed you that the Surpass is an excellent evolve. I mean, I'm talking the Surpass Evolve is an excellent flow diverter because this is a complex anatomy. You could see the curves. You could see a very, very tight loop with the stenosis proximal to the aneurysm. But all these segments was adequately treated by the pull push technique and a little bit of massage and finally the balloon to ensure adequate position. And we realized the balloon was not necessary for that tight loop. It was necessary for the segment just above the neck because whenever we put pressure on the flow diverter, It tend to bulge more into the neck of the aneurysm rather than onto the wall of the aneurysm. And that's the summary of this case. I think we got some great products on board, and we are very, very happy with both the surpass ball and the synchro support. And I believe these are the, the hardwares that have come in the recent past, which allow us to succeed in cases which we normally would have given up.